Hi, everyone. It is my great pleasure to introduce Dr. Kate Wolitzky-Taylor, who is a clinical psychologist and an associate professor in residence in the UCLA Department of Psychiatry. I've had the pleasure of working with Kate as a colleague at UCLA Integrated Substance Abuse Programs and now our Addiction Psychiatry Division. She also has affiliations in the Department of Psychology's Anxiety and Depression Research Center and in the Depression Grand Challenge. Dr. Wolitzky-Taylor has been funded by the NIH since her doctoral training for her work in improving behavioral treatment for anxiety and related disorders, most recently with an emphasis on the comorbidity between anxiety disorders and substance use disorders. She obtained her PhD in clinical psychology at the University of Texas at Austin, where she received training in the laboratory for the study of anxiety disorders. She completed her pre-doctoral internship at the Medical University of South Carolina in the traumatic stress track and her postdoctoral research fellowship at UCLA in the Anxiety Disorders Research Center. Dr. Wolitzky-Taylor is currently a PI for several NIDA and NIMH-funded projects, including an NIMH-funded Alacrity Center. She also provides direct clinical service and supervision to our trainees in the delivery of cognitive behavioral therapy for anxiety, depression, and substance use disorders. And with that, I will now turn things over to Dr. Wolitzky-Taylor.
Thank you so much, Larissa, for that really nice introduction. I'm really looking forward to speaking with all of you about integrating treatment for comorbid anxiety and substance use disorders. And I should say right up front, when I'm talking about treatment today, I'll be specifically talking about cognitive and behavioral therapies. So leaving medication out of it at the moment. So as I'm sure most of you know, anxiety and substance use disorders are highly comorbid, and this comorbidity is associated with greater symptom severity, impairment, and healthcare utilization compared to having just one of these problems. It's also associated with poorer substance use treatment outcomes and poorer engagement in addiction treatment. So it's an important public health problem to address. It's also important to point out that anxiety and substance use disorder comorbidity is observed across the anxiety disorders and across a variety of substances of dependence. So it's really not limited to any specific anxiety or substance type combinations. There have been many theories that have attempted to explain or understand this comorbidity, and most center around the idea that some individuals with anxiety will begin to misuse substances to cope with or alleviate anxiety, which of course is negatively reinforcing and leads to a pattern of maladaptive substance use, and then over time, the onset of a substance use disorder. And these tension reduction or self-medication hypotheses account for about 75% of the cases in which we see the anxiety disorder onset precede the onset of the substance use disorder. In the other 25% or so of cases, we see it go the other way around, with the substance use disorder starting first. And these cases can be explained by the substance-induced anxiety enhancement theory, which basically suggests that multiple withdrawal or intoxication experiences can engender anxiety, and that over time that anxiety may take on a life of its own, and then you have the onset of an anxiety disorder. But more recent models suggest that it doesn't really matter which one started first. Once a person has both problems, they serve to mutually maintain and exacerbate one another. So if we take just a really classic common example of social anxiety disorder and alcohol use disorder for a moment, in this case, the social anxiety symptoms typically are starting first. And then an individual may self-medicate with alcohol in this case, and social gatherings and social events, which of course in the short term reduces anxiety, but of course is negatively reinforcing, and so leads to more and more alcohol use, and then over time an alcohol use disorder. So now maybe this person is developing, drinking more than they planned, developing some tolerance, maybe alcohol use is starting to cause some problems. And then in this case, as the alcohol use disorder becomes more severe, either multiple withdrawal experiences or maybe even just the consequences of having an alcohol use disorder increase anxiety. So for example, maybe this person now is getting really intoxicated at parties and even blacking out, and then their friends are telling them something really embarrassing that they did the next day. And so now they're engaging in some post-event rumination, and that's just fueling more social anxiety symptoms. So what should we do? Well, according to these models then, treating anxiety should improve substance use disorder outcomes, and in particular, integrated approaches that simultaneously address both problems should break the vicious cycle. Unfortunately, that's not usually what happens. So let's talk about the limitations of the current landscape of care for comorbid anxiety and substance use disorders. For many decades, as I'm sure many of you know, the zeitgeist was to tell patients with this comorbidity, go and get your addiction treated first, then come back and get your mental health problem treated. And the field, I think, is finally starting to recognize the limitations of this approach and that this doesn't really work very well. But despite this somewhat improved awareness of the need for integrated treatment, substance use disorder and mental health care continue to typically remain siloed at many levels. So as early as training, when we think about as clinicians, how we're trained in these subspecialties, usually kind of specializing in one or the other, and then we go out into the world and practice as clinicians doing the thing we were trained to do. And that's reinforced by these systems of care that are also remaining siloed. So still to this day, unfortunately, the average addiction clinic is not diagnosing or treating underlying anxiety disorders, certainly not using evidence-based treatments to do so. And on the other hand, most mental health programs are continuing to refer out for addiction treatment, but we know that most people don't end up receiving it. So as clinicians, we know that the likelihood that someone is going to go establish care at this place you referred them to, successfully complete a course of treatment there, and then come back and complete the treatment that they came to see you for, it starts to get pretty unlikely. And so what happens is that this siloing of care creates barriers to accessing treatment, but also it's providing inadequate clinical approaches to address these complex patient populations when we think about that mutual maintenance that I just showed you and how these are functionally related. And then even in cases in which a patient is provided with treatment for both problems, the treatment tends to be sequential, like I just mentioned, or in parallel, meaning the person's getting two different treatments completely in isolation and nobody's talking to each other. And early clinical trials trying to address this comorbidity show there are major limitations to these approaches. So that has led me to develop a program of work really aimed at the development and evaluation of integrated treatment approaches for comorbid anxiety and substance use disorders. And there are many different angles that we could look at this problem from. There are many different ways we can address it. I'm going to talk about some of the ways that I've done so. But before we talk about what an integrated treatment might look like, let's just take a step back and look at the components of CBT for anxiety disorders and substance use disorders when they're separate, which is how they're typically delivered. And I know many of you probably know this, so we don't have to spend too much time on it. But a traditional multi-component CBT package for anxiety is going to include some psychoeducation about fear, anxiety, the physiology of fear, panic attacks, some cognitive restructuring, and then hopefully a lot of exposure to feared and avoided stimuli, because arguably this is the most effective component of treatment for anxiety, but unfortunately is used the least frequently in community practice. And then for substance use disorders, when we're talking about CBT, a traditional package, there's also a lot of psychoeducation, obviously about different topics, things like what's happening in the brain when a person is using substances, maybe some stuff about withdrawal, things about triggers. The cognitive restructuring tends to be a little bit lighter. So it's less about learning a specific skill for thinking more accurately or flexibly. And it tends to be a little bit more about helping patients just identify cognitive distortions and catch themselves in the moment when they're using what we call relapse justification statements. And then the behavioral component is really the relapse prevention and coping skills tools. And this is where the meat of the treatment is for substance use disorders as well. So this is things like identifying internal and external triggers for use, coming up with coping plans to hopefully avoid those triggers when possible, but if not possible, coming up with plans for managing high-risk situations, and then just generally kind of working on more alternative adaptive behaviors. So that's what they look like separate. Now, what about when we want to adapt CBT for anxiety disorders into substance use disorder treatment? Well, here are just some of the considerations that I've been thinking a lot about, and I'm sure there are others that other people are thinking about. So the first is just what kind of treatment are we talking about? Are we talking about an adjunctive anxiety treatment where patients are already undergoing substance use disorder care and we want to weave in some of that anxiety work in a meaningful way? Or are we talking about a standalone, fully integrated intervention that's combining components of CBT for anxiety and substance use disorders in meaningful ways, where theoretically, if a patient gets this treatment, that presumably may be all they need to address both problems? So what is the nature of the treatment? The other thing when I'm thinking about adapting CBT for anxiety disorders into community-based care in substance use disorder treatment settings, I really want these interventions to fit within the structure and culture of these programs to increase the likelihood of adoption and sustainability in community care. So the first thing that's usually obvious to me is let's put this in a group, because we know that group is the most common treatment modality in substance use disorder specialty clinics. That's perfectly fine. CBT for anxiety disorders works perfectly well in a group. I'm also thinking about making these treatments as brief as possible and really focused on core ingredients of treatment. And the reason for this is because the clinics and the patient populations that they serve are often under-resourced, and we don't know how many sessions we're going to get with a patient. And so we really want to get the most bang for our buck, so to speak. We want to make sure that we're giving patients what's going to work the best as quickly as possible. And then when I'm thinking about full integration of content, what I'm thinking about is really making sure that the psychoeducation is about that mutual maintenance model woven throughout treatment, that patients are constantly sort of thinking about how are my anxiety and addiction functionally related. I want to make sure all of my examples in the intervention are really reflecting this comorbid patient population and meeting their needs and things that really resonate with these patients. And then another kind of approach to full integration, which I'll talk about in one of the studies that I'll tell you about later, is to say, can we do this in a more parsimonious way? Rather than kind of lumping together components of these two treatments in meaningful ways, can we just go straight into targeting the processes that we know are implicated in both substance use disorders and anxiety disorders and are thought to mediate the associations between these problems? And I'll talk to you a little bit later about what that means. The other thing that I've spent a lot of time doing is thinking about how we want to address potential and inadvertent mixed messaging that patients may get when they're getting these treatments to put together at the same time. So for example, exposure is basically telling patients to approach the internal trigger of anxiety. Whereas a traditional CBT for substance use disorder model is kind of an avoidance model. It's saying avoid the triggers, avoid the people, places, and things. And so we have to spend some time really helping patients make the distinction between approaching that internal trigger of anxiety for objectively safe situations, that if a patient could go into that situation with more ease and less anxiety, that would probably improve their quality of life, versus avoiding those external triggers of use, like going to the liquor store or hanging out with your drug dealer, which we know obviously are really high risk, and we don't want patients doing that. And patients seem to get this. It's a distinction that needs to be made, but once it's made, it's pretty clear. So what does this look like? Well, the first study I'm going to tell you about is really my first attempt at trying to integrate these treatments. And this was a study called Coordinated Anxiety Learning and Management for Addiction Recovery Centers, or COMARC. So COMARC, basically what we did, we developed a brief CBT protocol for anxiety disorders to be delivered by addiction counselors in community substance use disorder specialty clinics. So this was a computerized but therapist-directed program. Basically what that means is that we had a web-based intervention that was guided by clinicians in a group, so that clinicians with minimal to no training in treating anxiety disorders or delivering CBT could learn it. So they did undergo training, but certainly not even close to the amount of extensive training that a CBT therapist would get typically. And so it was kind of like having a cheat sheet in front of them, guiding them through the group material. It included web-based assessment tools and homework components, so patients could go home and also log in and complete their homework. It was very brief. It was just 6 sessions plus an orientation session. It was very interactive. All the content was designed specifically for this comorbid population, including videos and examples, and I'll show you some screenshots in a moment. And it was evaluated in an effectiveness trial in a community-based substance use disorder specialty clinic. So here's just what it looked like. And this is just to kind of illustrate what an integrated treatment could look like. So for psychoeducation, we talked about anxiety, fear, panic attacks, like you normally would. But then we jumped in pretty quickly to having patients really learn about how their anxiety and addiction work together. We introduced the idea of alcohol and drugs as safety aids to mitigate or avoid anxiety in the short term, but which of course maintain anxiety in the long term by preventing threat disconfirming evidence from coming in. When we talked about the components of anxiety, and I know most people on here probably have had at least some basic CBT where you learn about the thoughts, feelings, and behaviors kind of cycle, we made sure that those examples were really in the context of craving and use. So what does this look like? Here are just a few examples that I'll take you through of the psychoed so you get the idea. So here's an example of alcohol as a safety aid. Imagine you're afraid of going to parties and meeting new people because you're worried others will negatively evaluate you. You're afraid people will think you're boring or unintelligent. There's often alcohol at the social events you attend, so you start to drink in order to reduce your anxiety. You find that this helps you get through these social situations with much less anxiety. Now you think it's a good thing I drank a couple of beers at that party. I had the courage to talk to people, and some of them actually liked me and thought I was interesting. Soon you believe you need alcohol in every social situation to get the same result and are drinking much more frequently and begin to develop an addiction to alcohol. So this is a pretty common kind of classic example. But then we also kind of gave an example of that mutual maintenance model, the idea that at a certain point, it doesn't even really matter where it started. So imagine you worry a lot about all sorts of things, your job, how you will pay the bills, and your relationship. All of this worry causes so much distress that you start to take prescription pills such as opioids or benzodiazepines to help you relax. Soon every day you get home and find that taking those pills is the easiest way to forget about it all. The problem is soon your time and money is being spent on getting, using, and recovering from taking the pills. You have trouble concentrating at work and end up losing your job. Your romantic partner is tired of you always using and not spending time together as a couple, and now you're fighting more. Money is getting tighter and tighter. This makes you worry more and more, so you need more pills to get through it. Now you're addicted to the pills and your worry feels too difficult to manage without the help of the drugs. And so I think this type of example also really resonates with patients by the time they get into care. And then just finally, this is an example of how we might present the components of anxiety. This part on the left, this image is probably pretty familiar to many people, but how might this work in the context of substance use disorders? And I will say, I got a lot of these examples just sitting in on groups and listening to people talk and then kind of formulating it in these types of examples. So you know you'll be going out to dinner with a few new friends you just met in class. You are anxious about getting to know the new people. You think they will think I'm weird. This makes you more anxious. You may feel the physical sensations of anxiety. You think I will be more relaxed if I smoke some weed, so you behave by smoking weed. You go to the dinner while you're high and realize that it's harder to make good conversation while you're high than you expected. This makes you more anxious and you begin to feel the physical symptoms like feeling detached. You think now they will notice I'm anxious and really think I'm weird, so you behave by not talking and you leave as soon as you can. Okay, so that's the psychoed. That's really woven throughout is this idea. Cognitive restructuring, we focus on the two most common thinking errors in anxiety, the overestimation of likelihood of a negative outcome occurring, and catastrophizing. So thinking that if that negative outcome did happen, it would just be awful. I'm not going to go into too much detail here. We could have whole lectures on cognitive restructuring, but essentially, we're teaching patients how to identify their anxious thinking and challenge that thinking, kind of come up with alternative, more realistic and more flexible and more helpful ways of thinking about these anxiety-provoking situations. Exposure, we jump into this as soon as possible. We start this in session 2 in ComArc. And we go through a series of exercises where we help patients identify avoided situations, memories, images, and bodily sensations. So it's very much a transdiagnostic kind of approach. And then we help them create a fear hierarchy. And we do in-session exposures as a group, as well as homework exposures that are assigned. So here's just an example of a fear hierarchy, what one might look like in ComArc. Or really any of these integrated treatments that I'm going to tell you about. And you can see here, again, we're kind of weaving through this classic example of social anxiety and alcohol use disorder. Here you can see that we're trying to kill two birds with one stone. We're trying to do exposure and in the process, help the patients get engaged in their substance use disorder treatment, or in this case, their alcohol recovery. So the kinds of things on their fear hierarchy are things like approaching someone at an AA meeting and having a conversation, reading a passage during an AA meeting or a group, things like that. And so, patients complete an individualized fear hierarchy really based on their own kind of fear and avoidance. Here are just some screenshots just to give you an idea. So this is obviously just like a login page, and patients and counselors would have access to various materials at different times. Here's just a screenshot of one of our cognitive restructuring forms. So the clinician would take the patients through maybe someone from the group's example, type things in, save it. The patients would be doing their own hard copies in the group. And then they could go home and log in and they could see the example that was saved, and they would also have blank forms that they could complete on their own. This is an example. This is what the fear hierarchy looks like that they would fill out. One thing that was really important was we created videos for any skill that was challenging, maybe for a new clinician delivering this to do, so that they really didn't have to demonstrate anything complicated or difficult. They just had to show the video and then basically copy what was done in the video. So here you can see that they would just show a video. In this case, it's of me conducting an interoceptive exposure assessment with a patient. They would watch what to do, they would copy it, and then move on to the next thing. So as far as the actual clinical trial, recruitment was done through a collaborative referral process with the clinic. Patients who were eligible were randomized to either ComArc plus usual care. So I should say this is an adjunctive intervention. Everyone was getting an IOP level of care, the matrix model, which is an evidence-based treatment, or they were getting just the matrix model IOP for their substance use disorder. And we matched for therapy time by having patients in ComArc not go to the family education sessions while they were getting their ComArc treatment. So everyone was getting the regular substance use disorder IOP, and then some people were also getting ComArc. And then they completed their 7 weeks of the acute phase of treatment. So either the weekly ComArc sessions or just matched weekly assessments in the control group, and then a post-treatment and a follow-up assessment. Here you can see the demographics of the participant sample. It was primarily white, so unfortunately it was not a very racially or ethnically diverse sample. Slightly more males than females, mean age of about 36. When we look at anxiety disorder diagnoses and comorbidity, on the left, you're looking at the principal anxiety disorder diagnosis, and this maps on perfectly to the epidemiological literature and what you would expect to find. So the most common principal anxiety disorder was GAD, followed by social phobia, and then the rest. But you can see here on the right that most people had more than 2 anxiety disorders. So there was a lot of comorbidity just among the anxiety disorders. And then a sizable proportion also had a current major depressive episode at the time, nearly half. When we look at substance use disorder diagnoses, you can see here on the left that the majority of the sample met the substance use disorder criteria for 2 or more substances. So there was a lot of polysubstance use in this sample. But on the right, when you look at the primary substance of dependence, more than half, it was alcohol, and then kind of a relatively even breakdown of the other drugs. Here you're looking at change in anxiety symptoms over time from pre-treatment through the 6-month follow-up. The blue line is ComArc and the red line is usual care. And you can see here that anxiety decline slopes were significantly steeper in ComArc compared to usual care. And the same pattern was found on our PHQ, on our depression scores as well, even though we didn't target depression. And this is fairly typical when we give CBT for anxiety to patients. Often their depression remits as well. But I thought this was kind of nice to show. As far as substance use outcomes, here you're looking at drinking days in the past 30 days on the timeline follow back. And you can see here that those in ComArc are reporting fewer drinking days at post-treatment than usual care. And that finding was maintained over the follow-up period. And we found a similar outcome for drug use days. And you may be looking at the y-axis and thinking they're not really using that much at pre. So you have to be thinking about this is an intensive outpatient level of care. For many patients, not all, but many of them have already stepped down from higher levels of care. And so by the time they get into this treatment, maybe they're already abstaining or trying to abstain. And we want to just see how long can we keep that pattern going. And you can see here that we are keeping that pattern going significantly better in ComArc than in usual care. So in sum, it was feasible for addiction counselors to learn this treatment with this delivery method. And I didn't talk about the fidelity data just in the interest of time, but clinicians showed very high levels of adherence and competency when using this model. And the findings suggest that a very brief treatment, even with moderate engagement, improves anxiety outcomes and substance use outcomes. So I also didn't mention this, but patients only completed an average of 4 out of 7 sessions. And on the clinician homework ratings, they only completed about half of their homework. And despite this, ComArc outperformed usual care on substance use variables. And this is really key because this is what lends support for the benefit of adding an integrated approach to treating anxiety for patients in substance use disorder treatment. So that takes me to the next step. So the next thing I wanted to do is say, can we go beyond just an adjunctive intervention? And what about creating a standalone, fully integrated treatment that combines the components of both of these treatments to address these problems that maybe if a patient gets this, that's all they would need. And so that takes me to the fully integrated treatment for comorbid social anxiety and alcohol use disorder. So why social anxiety and alcohol use disorder? I know I told you that we see this comorbidity across the anxiety disorders and across a variety of substances of dependence, and that is true. But this one kind of keeps coming up because social anxiety disorder is a unique risk factor for alcohol use disorder. We see this over and over in longitudinal studies. And social anxiety and alcohol use disorders are highly comorbid. This is probably one of the most prevalent of the comorbidities between anxiety and substance use disorders. And compared to those with only one of these disorders, having this comorbidity is associated with all of those poorer outcomes that I mentioned at the beginning, especially poor engagement. And I think this is because it's all done in groups, that patients are reluctant to kind of engage in this group platform. So what are the current clinical paradigms for the treatment of this comorbidity? Kind of like what I was saying before more broadly, these are typically separate treatments, typically done in separate clinics. Patients with this comorbidity are more likely to show up at an addiction treatment setting compared to a mental health setting where social anxiety is typically not identified or treated. Those who do show up at a mental health clinic are often still sent off-site to go get their addiction treatment prior to receiving their social anxiety treatment. We've talked about the issues with barriers to accessing care when we do this, but perhaps at least as importantly, if not more importantly, thinking about how these are functionally related, clinically, this doesn't make a lot of sense. So the aim of the study was to develop a fully integrated outpatient or intensive outpatient level of care for alcohol use disorder and social anxiety disorder, an evidence-based protocol, which we called FIT, guided by previous research and focus groups with patients, clinicians, and administrators at a community-based outpatient substance use disorder specialty clinic. I'm not going to be talking too much about that phase of the study. Happy to answer questions about it. That was kind of the development phase. But what I'm going to be talking about is us gathering preliminary data to evaluate the effectiveness of FIT among patients with comorbid alcohol use disorder and social anxiety disorder at a community-based substance use disorder specialty clinic. So what were the treatments? So the fully integrated treatment, basically, as many of you may know, in an intensive outpatient program, patients are kind of entering and leaving on a rolling basis. And I didn't think it was really going to work out to just send someone in on day one to start doing social anxiety exposures without any background. So what we decided to do was have what we called an ultra brief lead-in group, where any new patients in the trial who were randomized to FIT that week got basically a crash course in CBT for social anxiety and alcohol use disorder. They learned about the mutual maintenance model that I've been talking about. They learned a little bit of self-monitoring, an introduction to cognitive restructuring. They got the rationale for exposure, and then they worked with the clinicians to develop individualized in vivo exposure fear hierarchies. And here, what we're trying to do is, rather than see this group session kind of modality as a barrier to care, we're seeing it as an opportunity. So can we use this as a platform for exposure? And then once they got that kind of crash course, then they went into the rolling IOP and they got their full IOP care, where we reiterated the mutual maintenance model through patient examples that came up when they would check in. They would get an alcohol use disorder topic. Again, this was borrowed from the matrix model, but it was tailored for patients with social anxiety. We did in vivo exposure to social situations. Again, much like that fear hierarchy I showed you before, where we really emphasized social anxiety exposures that would also enhance their alcohol use disorder recovery. And then we went over homework, assigned new homework, went through coping skills for alcohol use disorder and social anxiety disorder. The treatment, the usual care treatment as usual, was the matrix model of addiction. So this is a very stringent control group for a pilot. We know that this is already an evidence-based treatment that's been rolled out in many places. Patients got 9 hours of group treatment per week in both conditions. That's the IOP level of care. Matrix is a CBT-based treatment with some 12-step facilitation. And although there is some coverage of handling difficult emotions, it's really in a strict coping model. So it's very distinct from an exposure-based therapy. Here's just a very busy slide with a lot of numbers showing you the participant flow through the study. You can see here, this is a pilot study when we're looking at these sample sizes. So you can see 56 participants were eligible and randomized to FIT or usual care. And then went through treatment and completed assessments at mid-treatment, post-treatment, and follow-up, 6-month follow-up. Obviously, everyone had social anxiety and alcohol use disorder, but you can see there was a lot of other comorbidities. So over half the sample had a current major depressive episode at the time of enrollment, lots of other anxiety disorders, PTSD, and other substance use disorders. This was a much more racially and ethnically diverse sample, which is great, relatively even gender split, and a mean age of 40. Here you're looking at the change in the Leibowitz social anxiety scores over time. On the left, you're looking at the fear subscale, and on the right, you're looking at the avoidance subscale. FIT, our experimental condition, is the dotted line, and usual care is the gray line. So you can see here that fear and avoidance, social fear and social avoidance, declined significantly more in FIT compared to usual care. And then when we look at change in drinking days in the past 30 days on the timeline follow back, we also found the same pattern of findings. And so this is really kind of the exciting piece here. So in sum, we turned a barrier into a facilitator. So fully integrating treatment for a common comorbidity is feasible and acceptable in a real-world substance use disorder specialty clinic. Again, I didn't talk about this, but the clinicians who did not have the digital cheat sheet this time, we really just spent a lot of time training them. They were able to learn the intervention and deliver it with fidelity. And patients were able to engage in care and use the group setting as a platform for exposure. Importantly, improvement was observed in both social anxiety and alcohol use outcomes to a greater extent than an evidence-based IOP for alcohol use disorders alone. And so again, here, this is lending support for the full integration of anxiety and substance use disorder treatment, this time as a standalone intervention in community-based settings. And then finally, the last study that I'll tell you about takes a totally different approach. I kind of alluded to this at the beginning, and this is called targeting maladaptive responding to negative affect in adolescent cannabis users. And here we're just going straight to a process that we think is accounting for this comorbidity. So just to give you some background, cannabis use disorder is elevated among individuals with emotional disorders. So what I mean by that is anxiety and depressive disorders. We know that individuals with emotional disorders view negative affect as more aversive than those without, and they engage in reactive strategies to eliminate or reduce negative affect, which actually has a paradoxical effect and tends to maintain or exacerbate symptoms. There are several related constructs. I'm talking about things like anxiety sensitivity, negative urgency, distress intolerance, various facets of emotion dysregulation that reflect this maladaptive responding to negative affect and are also associated with substance use disorders. And many of these constructs have been shown to statistically mediate the associations between emotional disorder symptoms and substance use disorder symptoms. So they're accounting for this comorbidity. So the idea here is to say, okay, we need to target that. We want to target the shared underlying processes that are linking emotional disorder symptoms to substance use as a much more streamlined, parsimonious way of addressing this problem. In this study, we focused on late adolescents or emerging adults. Why? Well, this represents a time of rapid emotion regulation development. We see that, the patients in our study are kind of veering in one direction with maladaptive emotion regulation strategies, and we want to kind of set them on the other course, basically. This is also a time of high risk for the onset of substance use disorders, particularly cannabis use disorder. So here's the model that we're basically working with. The idea being that some people, when they have elevations in negative affect, will then maladaptively respond to that negative affect. And there are several ways that they can do this. So there could be cognitive maladaptive responses, such as misappraisals, including misappraisals of one's own physiological symptoms of anxiety, which is anxiety sensitivity, or other misappraisals. There could be thought suppression, experiential avoidance of thoughts. There could be maladaptive behavioral responses to negative affect, the most obvious one being avoidance, but it could also be negative urgency, which is the propensity to react impulsively, behaviorally to negative affect. And then we have emotional maladaptive reactivity to negative affect. And so these are things like distress intolerance, or experiential avoidance of emotion. And we know that all of these things lead to increases in substance use, which of course is then negatively reinforcing. So we see a temporary reduction in that negative affect, and that just kind of keeps the cycle going. So, really there should also be an arrow kind of pointing back up to the elevations in negative affect. So the idea with this study was to say, we're going to target that stuff in the middle that we think is accounting for this problem. So the primary aim of the study was to develop the affect management treatment for cannabis use disorder, we called AMT, using an iterative process. Again, I won't be talking too much about that process today. And then we compared the effects of AMT to CBT for substance use disorders, which is the gold standard behavioral treatment for cannabis use disorder. We compared these conditions on cannabis use and responses to negative affect among 18 to 25-year-olds. So both treatments included 12 sessions of individual therapy. And in both treatments, the first session was a motivational interviewing session. After that, for AMT, the first half was really about providing education and building skills. So we went through mindfulness, cognitive reappraisal, and problem solving. And then the second half of the treatment was basically exposure. So we taught patients how and when to utilize those skills in different contexts, but we really focused on exposure in the context of reducing, responding to negative affect inducing cues that are also cues for cannabis use. So facing distressing stimuli that might also lead to a craving And this looked very different for many people. This was, as you can imagine, a very kind of transdiagnostic approach. And we compared this to standard CBT for substance use disorders. We used a manual for adolescent cannabis use disorders. So again, like with the other study, a very, very stringent control group for a pilot study. Here again is the busy slide with all of the numbers, just kind of taking you through the flow of the study. Again, this was a pilot sample, so you can see 52 participants were eligible and randomized to AMT or CBT. You can see here there was some attrition. Part of this was we had a lot of UCLA students, and some of this occurred during the COVID shutdown when everyone went home. So we kind of scrambled to move virtually, as I'm sure many of you remember that time. But nonetheless, even that aside, there was just quite a bit of attrition as well. Here are the participant sample demographics. You can see the gender breakdown here. It was a pretty racially and ethnically diverse sample. Patients did not have to meet criteria for an emotional disorder to be in the study. They just had to have cannabis use disorder and then have elevations on dimensional measures of negative affect and at least one construct representing maladaptive to reactivity to negative affect. But you can see here there was a lot of psychopathology in this sample, including moderate to high suicide risk present in a pretty sizable proportion of the sample. I would characterize this sample as having a lot of affective instability and emotion dysregulation. So of course, everyone had cannabis use disorder. You can see about half also had an alcohol use disorder. You can see here that these 18 to 25-year-olds were using quite a bit of cannabis. So at baseline, they were using about 22 out of 30 of the past days in the month. And when they were using about 3 times a day. So here you're looking at the negative affect subscale on the positive and negative affect scale. Here, AMT is blue. So again, our experimental condition is blue, and CBT is our control condition this time, and that's red. And you can see here that negative affect was declining significantly more steeply over time in AMT compared to CBT. The same pattern was found when we looked at anxiety sensitivity on our self-report measure of anxiety sensitivity. We also completed a behavioral laboratory task tapping into anxiety sensitivity where we induced hyperventilation. And then had patients rate their peak fear during the hyperventilation induction and also how much cannabis craving they had. You can see here on the left that AMT is outperforming CBT in showing steeper peak fear decline slopes over time compared to CBT. So they're having less fear response to the hyperventilation task. And then if you look on the right, both groups are showing improvements or decreases in craving following the task with no differences between groups. So that's good. We would hope that CBT, which is our gold standard, would be doing some good stuff. This is the distress tolerance scale. Higher scores indicate better distress tolerance, so increases are a good thing. You can see here that both groups are showing significant improvement in distress tolerance over time with no differences between groups. But then we gave a behavioral laboratory task of distress tolerance called the mirror tracing task. I won't go into too many details. It's basically a really frustrating computer task. And we asked patients to rate their peak distress during the task as well as their craving. And you can see here the same pattern as with the hyperventilation task. So those in AMT are showing significantly steeper declines in distress after completing the mirror tracing task over time from pre through follow-up. But both groups are showing decreases in craving. As far as cannabis outcomes, on the left, you're looking at the total number of times that a person used cannabis in the past 30 days. So this is kind of like a quantity measure. Whereas on the right, you're looking at just how many days did they use cannabis in the last 30 days. You can see here that AMT is showing this is marginally significant declines that are marginally significantly steeper than CBT on the total number of times that they're using across the study period, whereas both groups were showing improvements in just the number of days that they used cannabis with no differences between groups. And there's one thing I didn't mention about the treatments is that CBT for substance use disorders, we took a pretty typical abstinence goal kind of approach. Whereas in AMT, we told patients, we just want them to stop using in response to their negative affect. So it was much less of it wasn't an abstinence model at all, really. It was really just, can we reduce use in those contexts? And so I think this is actually kind of what I was expecting might happen, even though we are seeing no differences between groups on the just number of days when they're using less. And so in sum, there's some preliminary evidence with a small sample size that AMT is outperforming CBT in decreasing negative affect and several constructs that represent maladaptive responding to that negative affect, which we know are implicated in the maintenance of substance use disorder. AMT was at least as effective as CBT, which is the gold standard treatment in reducing cannabis use. And there was some signal that it may reduce the total amount of use more than CBT, but obviously larger samples are needed. Replication is needed for a study like this. As I mentioned, this was a difficult population to recruit and retain. And those who did kind of stick with it really only had moderate adherence. And so I'm really interested in thinking about how we can engage these patients in treatment more and thinking about what that kind of next step would look like. So just some concluding remarks. There's ample evidence to support the benefits of integrating anxiety disorder treatment into substance use disorder treatment. There are many ways it can be done. There are not a ton of us doing this work, but there are a few others besides me, so I'm sure other people are coming up with other ways to do this. Unfortunately, though, the field remains siloed and more work is needed to change clinical practice paradigms that I was talking about earlier. And in my opinion, this starts with training clinicians in their training programs to deliver integrated care so that they can then go out and practice that wherever they go on after they complete their training. And provide those services. And then when patients know about them and there's more uptake, I think the demand on the system to provide those will be greater. And that's it. So I just want to thank my many collaborators on the projects that I mentioned today, my staff on those projects, the funding agencies for those projects, and the many, many clinicians and clinic partners who really made this work possible. I could not have done any of this without them. And I will stop there and we can open up for questions.
Wonderful. Thanks so much for such an interesting presentation that pulls together your various areas of work. Moving to questions, we do have a question in the chat that was posted during the presentation about the FIT study, though it may be a broader question. Given low self-worth, do you focus on what their strengths are, such as not being so social, may create strengths in other areas, for example, visual spatial in woodworking, encouraging working in those strength areas so that the changes last?
I think it's a really interesting question. And I would say where this comes in is actually in one of the alcohol use disorder or substance use disorder kind of components that we include, which for any of those who are familiar with the matrix model or even behavioral activation, it's really about scheduling activities. And so I think one thing that goes kind of the assumptions that are made when someone's social anxiety is not being considered are, oh, let's put a bunch of like, sober social support activities on here that'll be really fun and, get you going out and doing things. And those are not necessarily fun. And to this point, maybe not necessarily what their strengths are or what they're looking for to fill their time with healthier, more adaptive activities. So I think where this comes in is just that recognition and acknowledgement that, when we're creating an activity schedule, let's think about what is actually meaningful to this person. What are their values? What is important to them? and I think sometimes now that social anxiety has been identified in this patient, that kind of component can be thought about in a different way. So it doesn't necessarily come up in the exposure piece as much as the other pieces.
Great. Another question, before even moving to an integrated treatment model, which you certainly very convincingly presented arguments that these are ideal models of care for behavioral treatment for co-occurring disorders. How does a clinician address in a short visit the common misconception, but I need to smoke cannabis or drink alcohol to reduce my anxiety, to even get started in my day? When I don't, I feel worse. I feel more anxious. When, as a clinician, you may perceive that these substances are actually causing those symptoms or problems or making them worse. What's the first step to even move the patient along to that direction of accepting treatment?
That's a $1 million question, but I think it really goes back to like making sure they understand how these problems are functionally related from day one. So really presenting that mutual maintenance model. And we've created handouts where we have them really think about, like we kind of spell out, here are all the ways that my anxiety and addiction might be tied together. And it can be kind of eye-opening where, we just say, check these off. That they may never have thought about. And I think we really talk a lot about the function that the short-term relief is there, right? Like it does make you feel better in that short term, but what is it doing in the long term? It's keeping you from learning that the things you're afraid of happening probably aren't going to happen, that you could handle them without drugs and alcohol, and that if something goes sort of wrong, it's not going to be this catastrophe. Mm-hmm. And then as far to your question about that the substances are actually making the problem worse or causing some of this, I think we spend a little time specifically with cannabis talking about this, because I think this is where this comes up the most, that patients will say, well, I need it to relax. I need it. And when I don't use it, I am more anxious. And we we give them education to help them recognize that could be a withdrawal symptom. And that actually, now we're kind of in this chicken and egg problem, and this is kind of how we're going to intervene.
Okay, great. Next question, kind of a two-part question from the same individual. Great study. For the slide on anxiety sensitivity, hyperventilation task, was the effect beta of CBT on hyperventilation peak fear significant? It appeared, part two, that CBT increased post-fear ratings. Yeah, I have been asked that before. I'd have to go back to the data. I don't think the increase was significant. There wasn't a significant within group increase. It kind of looked a little bit like it was going in that direction, but I don't think that increase was statistically significant. Okay, great. Next question. You mentioned many participants in the final study were moderate to high suicide risk. This seems like it would be a large concern for many people attempting to develop programs in this integrated area. Are there components to the approaches you used that you would change or modify with this in mind? Yeah, I think this is a really good question. So I should back up and say that the diagnostic interview we used has this suicide module that kind of puts people at like no risk, low risk, moderate, or high. But even with the high, it's sort of chronic high, like anyone who is at acute risk for suicide was not entered into the study. So if someone actually, needed to be hospitalized or needed a higher level of care, they were excluded. So what you're left with there, I think, are people who have moderate to high, more chronic suicidality. And I think, I would speak to kind of the DBT literature there, because I think you're going to see a lot of that same stuff, where I think just a lot of training for people who are going to do these kind of interventions in suicide risk assessment, suicide risk management, knowing when it's time to go up to that higher level of care, things like that. So I would think about it in the same way that we might with any other kind of high risk population. Okay, great. Next question. How do we move, or is there any thoughts on eventually moving some elements of these integrated treatments into general healthcare settings? How do we partner with them more? Is it, for example, use of telemedicine to link with a specialist who's not embedded in that clinic, or consultation with a specialist, or, for example, use of apps, digital health, technology-based behavioral treatments that could be delivered through other means? Any thoughts about that? Or is this really just the job of the specialist? We have to refer them out.
Well, I would hope, I mean, maybe yes now, but I would hope eventually no. And I think all of the things you just listed are great ideas. That's why I think there's just the sky is the limit with how many things we can kind of think up to do this. I think we need good implementation scientists and health service researchers to help us think through, like, how do we bring that to these clinics? I think for sure telemedicine, but then who's going to deliver it is the question. And that's why I think kind of, I was speaking sort of to this pipeline problem that, like, if we're subspecializing so early on, then there's really no one to do these things. So if we have more people that are trained to do them, then wherever they go out into the world, whatever their clinical settings are, that could be something that they provide. So I think that's one way to do it. And then as far as to reach like greater numbers of people, I think digital therapies have a lot of promise to reach a lot of people. I certainly would have some reservations about digital therapy alone for someone like we just talked about in this kind of high suicide risk group, but certainly a digital therapy that might be augmented by some kind of clinical contact, or for patients with lower levels of severity, then maybe digital therapy alone could be okay.
Wonderful. Well, thank you. That concludes our, oh, one more that just came in. Do you think some of the failures of treatment in the past might be linked to the dissonance between exposure and avoidance messages not being in sync? It's a nuance that teens might not get unless specifically targeted. Ditto for adults.
Yeah, I mean, I guess there's no real way to know, but yes. So some of the early work that has not had good outcomes has been because the treatments weren't talking to each other. And that's why in every treatment that I developed, I spent a lot of time with the clinic director of whatever clinic we were embedded in and the clinicians themselves, and really tried to find places where something was out of sync. And, you know, we talked about a couple examples, even just with the activity scheduling that a patient might get. But certainly this idea of like, do I approach or avoid is a big one that I spent a lot of time thinking about how we wanted to get that right. And actually I thought, I don't know if this is going to go well or if people are going to get it, and people get it right away. So I think it just needs to be presented in a way that they can understand.
Wonderful. Well, we are at the top of the hour. Thanks again for such an excellent talk, and enjoy the rest of your day, everyone.
Thank you, everyone.